Hi, my name is Dr. Aria Kieft. I'm a PGY2 in radiation oncology, and I want to thank you for the opportunity to present my poster. The aim of this study was to determine if a brief case-based educational intervention would improve resident confidence in contouring a challenging post-lumpectomy breast case. Learning appropriate contouring of disease sites is foundational to the safe and effective delivery of radiation. Our department has 6 radiation oncology residents between PGY2 and PGY5. 5 were available to participate in the intervention and 4 completed all the surveys. The residents were provided before the intervention with a de-identified CT scan on which to draw the appropriate contours, a preoperative diagnostic mammogram, a breast MRI, the lumpectomy operative report, and the pathology report. The case was a stage 2A YP-T1C YPN1A M0 right-sided breast cancer, status post neoadjuvant chemotherapy, lumpectomy, and axillary lymph node dissection. This case was specifically chosen as the educational case because there was not a well-defined lumpectomy cavity and no surgical clips had been placed. Residents needed to use the other available information in order to delineate this particular volume. For a typical adjuvant radiation therapy case, such as this one, the radiation dose would be delivered first to the whole breast and the at-risk lymph node regions. Then a boost of more targeted dose would be delivered to the lumpectomy cavity. Residents were asked to contour the whole breast, the lumpectomy cavity, and regional lymph nodes, including the internal mammary lymph nodes, the axillary levels 1 through 3, and the supraclavicular region. The contours were then combined into a single plan, and a Hausdorff distance was calculated to assess the contouring congruence between residents. This also allowed residents to objectively assess the differences between contours. A pre and post survey was taken before and after the intervention. This allowed residents to assess their own level of confidence on a Likert scale of 1 to 5, with 5 being extremely confident. They assessed their confidence in contouring the case before and after. The intervention consisted of a 30-minute review of the combined resident contours with the attending physician with expertise in this disease site, after which the attending discussed a systematic approach to contouring similar cases. The level 1 axillary lymph nodes and the lumpectomy volumes demonstrated the most discrepancy with a 9.91 millimeter and a 6.63 millimeter mean distance, respectively. This was not unexpected as the lumpectomy cavity was ill-defined and the axilla had post-surgical changes. Residents were the least confident in their lumpectomy volumes with a mean of 2.25 with a range of 1 to 3 between extremely not confident and neutral. After reviewing their contours, discussing the differences between their contours with the attending, the residents actually felt more confident in what they had contoured, rating themselves at a 4.5 or ranging between 4 and 5, somewhat to extremely confident, and they felt more comfortable delivering radiation dose to their drawn contours. All residents agreed they felt confident about contouring a similar case in the future, and they felt the intervention was helpful. In conclusion, we felt this study demonstrated that discrepancy may be seen in target volume delineation and that trainees do face challenges in understanding which volumes are most appropriate to be contoured. We found a brief, focused teaching intervention with an expert in the subject matter can improve resident confidence in contouring a challenging breast case. We would like to expand this intervention to other disease sites, such as head and neck, to further enrich the radiation oncology curriculum. Thank you again for the opportunity to present this poster.